Thank you. Thank you to VitaFlow for inviting me to speak today. So today I'm going to discuss what a mitochondria is and the functions, which might seem quite basic, but I know sometimes it's been a long time since we've looked at them. What is mitochondrial disease, the evidence behind the ketogenic diet and mitochondrial disease, and a couple of case studies. So here we can see a picture of a mitochondria, and here is the outer membrane, which behaves a bit like a colander. It reduces the big particles getting inside the mitochondria. And then we've got the inner membrane here. And these folds here are called the cristae. These help increase the surface area. And then these also further sieve out the components that can go into the mitochondria just to the ones that were needed, so enzymes and proteins that are then found within the matrix. Here is the DNA, and as you'll see, it's ring DNA, whereas nuclear DNA is helix shape, so it's slightly different. All mitochondria have their own DNA as well. So the mitochondria are found within the cytoplasm of most cells in the body. They are complex structures that have their own DNA known as mitochondrial DNA. Their main function is to produce energy, but they also do remove waste by converting them into recyclable products that can be used within the body. The number of mitochondria found within a cell depends on the energy metabolism for that cell and also the metabolic function. Mitochondria need oxygen to produce energy through oxidative phosphorylation, which is done within the inner membrane. The TCA or Krebs cycle also occurs within the matrix, which is where glucose and ketone bodies are used to produce things that can be used, such as NADH and FADH2 in the oxidative phosphorylation. So types of mitochondrial disorders and diseases. So as you can see, there's quite a large list here, and the blue ones are ones that are seen with seizure activity. So it's thought that 40% of mitochondrial diseases have a clinical manifestation of seizures. There are also someone here that you will notice, such as VLCADs, that some of our metabolic colleagues will look after in terms of their dietary needs. Mitochondrial disorders are really rare, so this list will be ever evolving over time as more are found and more genes and things like that are identified. So what is a mitochondrial disease? Mitochondrial diseases are progressive disorders which are either inherited or occur from a spontaneous DNA mutation, which leads to the dysfunction or non-function of the mitochondria completely. The presentation of mitochondrial diseases can occur at any age, with a wide range of clinical manifestations, including epilepsy, hearing loss, liver failure, poor growth, and diabetes. These are just a few. There is a ginormous list. The symptoms will vary depending on the organs and body systems that are involved and have the issue with the mitochondrial. The severity of the disease depends on the percentage of the mitochondria that are defected in a cell. So you may have cells that have completely normal mitochondria next to cells that have 80% defected cells. It's thought that there's a compensation threshold that keeps things stable for a long period, and then something can occur and tip that threshold over, and we start to see the clinical manifestations. There is no treatment currently for most mitochondrial diseases. The treatment is usually supportive and treatment of the clinical manifestations we see. What is important is to reduce the mitochondrial stress that can be caused through things like infection, dehydration, illness, and physiological stress, because these can tip the balance from compensation into seeing these clinical manifestations. There are supplements that you may see. They're quite often called the metabolic cocktail, or the mitochondrial cocktail, which sounds far more interesting than they are. So these can include coenzyme Q10, riboflavin, and thiamine. These are thought to be more beneficial in complex 1 and complex 2 deficiency, but they are often used across the board because there's no evidence of harm. Progression of these diseases can vary between patients and can be unpredictable, but many children won't make it through to adulthood. Part of the issue with the threshold of compensation occurring is mitochondria do not have a robust DNA repair system, so over time they can be damaged by reactive oxidation species, and so these inflict damage to the mitochondrial DNA, and things like alcohol are included in that. So what is the evidence for the ketogenic diet in mitochondrial disease? As I've discussed, many of the mitochondrial diseases have a secondary manifestation of seizures. We know the mechanism for ketogenic diet is not fully known, so the thought is that we use ketogenic diet to help reduce seizure burden in children who have epilepsy alongside their mitochondrial disease. The evidence is very limited across mitochondrial disease. There are no RCTs. But generally, these are case cohort reviews or studies, or in animals or in vitro. It is well known not to initiate the ketogenic diet in beta fatty acid oxidation defects because we know we need fat to be metabolized properly, and also primary carnitine deficiency due to the fact that carnitine is essential for moving LCT fats into the mitochondria for metabolism to occur. And this can cause significant harm. So, potential mechanisms of ketogenic diet working in mitochondrial disease. Both of these studies these 3 studies are done in animals, so rice or mice even, or rats. The first paper here, Bao, found that the upregulation of the energy metabolism enzymes and mitochondrial proteins allowed for a greater biogenesis of mitochondria to allow better energy stores found within single cells, and these also helped protect against reactive oxidation species, protecting the mitochondrial DNA further. Malouf and Kim found that ketone bodies reduce the damage caused by the reactive oxidation species, which then further reduces the oxidative stress within the cell and therefore the damage that can occur. Malouf also found that beta-hydroxybutyrate and acetoacetate help prevent neuronal death in the glutamate-induced free radical formation. It is also thought that ketone bodies provide an alternative energy source to cells, which may improve clinical manifestations in some of these mitochondrial diseases. The efficacy of the ketogenic diet. So this is very similar to how we do it in epilepsy. It's based on the improvement in seizure burden, usually looking at 50% improvement. So Kang looked at 14 patients with varying epilepsy syndromes and mitochondrial diseases, all affecting different oxidative phosphorylation complexes. 10 patients responded favorably to the ketogenic diet. The side effects that caused cessation included recurrent or persistent hypoglycemia or metabolic acidosis. Lee looked at 31 patients, 24 which received ketogenic diet of some form. They were not all put on the same type of diet. 3 of the patients put on diet had to stop due to either severe infection or persistent metabolic acidosis. 75% of patients within the ketogenic diet group had a 50% reduction in seizures, but the majority of them had complex 1 deficiency. So PDH or PDCD, so that's pyruvate dehydrogenase complex deficiency or pyruvate dehydrogenase deficiency. Most of us have probably seen patients with this or have metabolic teams that start the ketogenic diet in these patients. It's a buildup of lactic acid that occurs causing lactic acidosis within the body. It can also cause production of energy within the cells to diminish, and cell death can occur. It's usually seen in infants not long after birth, and the symptoms are usually nausea, vomiting, and rapid breathing. The lactic acidosis can cause significant neurological effects in these patients, and it can be life-threatening if it's allowed to build up for too long without treatment. The evidence for this is based on case reports. So the top one, Falk, found in 2 brothers that if he provided sufficient energy from fat, that it reduced the blood pyruvate levels and helped improve growth and development in these children. Wexler reviewed 7 patients with different PDH mutations and varying ketogenic diet restrictions. It was found that the lower the carbohydrate restriction, or the earlier the diet was started, the KD showed better benefits in these children related to prognosis and also developmental progress. Weber found that the response to ketogenic diet varied, and that was across the literature that they reviewed. And Sufol was a Swedish population review, and they found that it was a safe treatment option and the benefits were seen related to ketosis. And it depended on the genetic defect that was found within the PDH. So MELAS. So MELAS stands for mitochondrial encephalomyopathy, lactic acid, and stroke-like episodes. So that's quite a mouthful, so MELAS is much easier to say. It affects many organs, including muscles, brain, and also the central nervous system. The signs and symptoms include muscle weakness, recurrent headaches, vomiting, and seizures. Most patients also have stroke-like symptoms by the age of 40. So this paper here, they both looked at a 22-year-old woman from Korea who had frequent episodes of status epilepticus, which decreased with the introduction and stopped with ketogenic diet. But magnesium and ketogenic diet was started at the same time, so it's difficult to identify whether it was the combination of both or just the ketogenic diet alone that helped stop these episodes of ketogenic diet, status epilepticus. So POLG, or ALPAs. POLG is the only DNA polymerase present in the mitochondria. Its function is to repair and replicate the mitochondrial DNA. So as you can see, this is a pretty rubbish repair mechanism within the mitochondria. Defects and dysfunction within the POLG results in mitochondrial depletion and cell death. One of the clinical manifestations is highly resistant epilepsy, and the evidence suggests that possible improvement to seizures but premature death remains in most cases. So Martocane introduced the low glycemic index treatment to a 26-year-old who presented with status and headaches. Multiple AEDs were introduced at the same time, and then the low glycemic index treatment was also introduced on day 4 of the PICU admission. There were improvements, so much so that she had no headaches and no further seizures. Cardenas introduced ketogenic diet and multiple AEDs into a 14-month-old patient with rapid disease progression. Very little detail is provided about the medical treatment in this case, and this is very similar to the presentation to the case study 1 that I'm going to go through now. So this is a case study of a child who presented at 8 months of age. She was admitted with status epilepticus requiring intubation and a 5-day PICU stay. She remained in hospital for 2 months. She was diagnosed with POLG on day 23 of admission. It was also seen that she had low complex 5, which is known to be associated with poor growth and also feeding problems. Complex 5 is where the ADP is converted into ATP. On day 21, the ketogenic diet was introduced. The team wanted an aggressive approach with the aim to get ketones quickly due to the significant deterioration over the weekend. The diet was initiated at a 2-to-1 ratio, consisting of ketocal 3-to-1 and cow and gate 1. And this included also non-counted breastfeeds. Although this does not sound like an aggressive treatment of ketogenic diet, she had only been receiving 50% of her feeds prior to this due to toleration issues, and it was anticipated that ketosis would occur quickly due to the starvation that had occurred over the previous days. So day 1, her ketones were 3.2 to 4.7. A speech and language therapist saw her and told Mum that she could no longer breastfeed due to the fact her swallow safety deteriorated significantly with the increase in seizures. Mum wished to continue breast milk, so EBM was used as an alternative to cow and gate 1, and all this was going via an NG tube now. Mum also then requested to stop expressing due to the stress this was causing her with the child who was so unwell at this point. Over the first 8 days, we saw an improvement to her seizures, but then unfortunately her ketosis was knocked out, and we still do not know why. It came out of nowhere. Her ketones dropped down to 1. So we persisted with the ketogenic diet, and we introduced some MCT to 20%. This helped boost her ketones to above 2 consistently. We met with the metabolic team who were reviewing her from the mitochondrial disease point of view, and they wished to increase the MCT to provide greater C10 and C8 because they felt that this may help allow better mitochondrial function. They also introduced metabolic medicines such as coenzyme Q10, riboflavin and thiamine. So we managed to start a 50% modular ketogenic feed, and ketones were stable at 3 millimoles per litre. The seizures did not improve to where they were before, but they were still better than they were prior to starting ketogenic diet. At day 87, she had a peg fitted, and this was because the NG tube wasn't a stable place for her meds and the diet to go through. She kept pulling it out or vomiting it. The progression of her pol G was unknown, so we don't know whether the ketogenic diet had an impact on supporting her life to be slightly longer. Unfortunately, the child died at 14 months of age. It was difficult to determine the benefit of the ketogenic diet in this situation. It was felt there were no signs of harm from the KD, so we continued it until she was admitted to hospital prior to death. So case study 2 is a young girl who we first saw at 4 years of age. She has West syndrome and trisomy 21. Her seizures started at 7 months of age with infantile spasms and evolved to drop seizures, atypical absences, and tonic seizures. Her medications were levetiracetam, clobazam, carnitine, sodium valproate, phosphate, omeprazole, ranitidine, and levothyroxine. She had a deranged carnitine profile at this point, but however had previously had normal carnitine profiles, and it was felt by the team that this was related to sodium valproate, and they wished to proceed with the ketogenic diet. The progression of her seizures were getting worse. She was peg-fed and also had a failed fundo. She was on Neocate Advanced at this point, but there were really significant poor toleration of this feed. She was vomiting. She was 2-week cycle of basically having feeds built up to 100% and then 2 weeks on diet-like. She couldn't tolerate it. Despite this, she was gaining weight excessively, and also her phosphate had decreased on the Neocate Advance. So we chose initially to use ketogenic diet via Ketocal and slowly add in new feeds every 5 to 7 days. On day 2 of starting the first feed, she was actually admitted to hospital. We don't know if this is related to the initiation of ketogenic diet, but it was agreed we would stop the ketogenic diet progression at this point and remove sodium valproate because they felt this was causing her significant problems. We also did further MCAD screening at the request of the metabolic team and the biochemistry team, and this was found to be negative. During this time, feeds were reviewed and we started her on Pepti Junior, and there was a significant improvement in her toleration of feeds and also her ability to sort of just be happier. She was opening her bowels better, but they weren't still quite right. Mum said it was the best she'd ever been on feeds. So at the age of 4 years and 8 months, ketogenic diet was reinitiated, and it was agreed to do this as an inpatient due to the issues with tolerance of feed in the past. We initiated her on a modular MCT-based ketogenic feed to mimic Pepti Junior where possible. So this is a bit of a complex graph here, but this is her journey on the ketogenic diet from start to end. The pink line here is the lowest ketones when I looked at her seizure ketone diaries. The orange is the high ones. The green bars are the MCT content of her feed, and then the blue line is her ratio of her feed. She was started on a 2.4 to 1 ratio in hospital, and over the first few days there was no concerns around tolerating her feeds, and her ketones were 1 to 2. So we agreed at this point to discharge her. This is where things started to become slightly more interesting. She went home and within 4 hours had ketones of 7.1, which was very unexpected given that morning that they were 1.1. Over 24 days, she had her feeds decreased to a 1 to 1 ratio because of repeated hyperketosis and the concerns around drowsiness related to this. We organised an urgent clinic appointment at Great Ormond Street to see her so we could get some further bloods done because they were concerned maybe she was had high lactate levels at the same time. So we started the 1 to 1 ratio at this point, which is here. Due to lethargy and her not being herself, her ketones decreased from 4 to 5 millimoles down to 1 to 2. And we decided that we'd leave it there for 10 days to see what actually happened clinically. And her seizures got progressively worse to the point where Mum phoned and said, I just want to go back on the previous regime because I'd rather treat her hyperketosis than see these seizures again. So we returned to a 1.5 to 1 ratio, and her ketones were shot back up to 3 to 6.7. But she was unwell again with drowsiness, so we reduced the ratio down to a 1.25, which is here. But we increased the MCT to 30%. But this kept her ketones between 1.5 and 6 millimoles, so you can see there's massive fluctuations over the day, and Mum was doing the ketones at the same time of day before feeds all the time. This caused increased retching, and Mum felt was related to the increase in the MCT, so we returned back to the previous feed, the 1.5 to 1 feed. So we went back to this feed here. And then slowly built up the MCT to 38%, because I was expecting that then I would have to reduce the ratio as I increased the MCT, but I didn't need to because her ketones were 2.5 to 4.5 at this point. Mum was then feeling that she wanted to get ketones above 4 because she felt seizure burden was better at this point. So we manipulated the feeds slowly over time because the ketones continue to vary. And we increased the ratio up to a 1.75 here. So as you can see, I decreased the MCT to make sure she didn't go hyperketotic due to an increase in ratio, and also the MCT was 38%. At this point, she had therapeutic ketosis between 2 and 6, which was the first time in a long time that there were no concerns about hyperketosis. But Mum was then still keen to further progress to get 4 to 6 millimole ketone levels. At this point, because of her strange behaviour to the ketogenic diet, her rapid hyperketosis that can occur, and also reintroducing feeds that she'd been on before, she didn't behave in the same way. We asked for a metabolic review. When she was unwell, she'd become rapidly hyperketotic, within an hour or two of not having her feed, but also if she has late feeds, her blood glucose levels decrease and she's symptomatic at 3.5 millimoles, so we treat there. She's not symptomatic other than drowsiness, but we're not sure whether that's related to hyperketosis or not. So it was agreed at this point, because the ability to switch from having sort of therapeutic ketone levels of 2, that she needed an emergency regime for when she couldn't tolerate any feeds. So we decided to start her on a 5% carbohydrate emergency regime, which dropped her ketosis so significantly that we have now agreed to go to a 2.5% emergency regime, but we're yet to try that one out because she's been so well recently. Within the metabolic appointment, she was diagnosed with probable diagnosis of secondary mitochondrial disease or involvement. So this shows that probably all of us have got children out there who haven't got a formal metabolic or mitochondrial disease, and they behave not as we'd expect to the ketogenic diet, and we still continue, but there is the potential that we'll never get a diagnosis for this child, but they feel very strongly that there is a mitochondrial disease element to her. She has currently been on the diet 8 months, and the benefits to her seizures are that she's not had any hospital admissions relating to seizures, whereas previously she had 8 admissions before starting ketogenic diet. They've also not had to use any buccal midazolam, which was used sort of every quarter at least when she wasn't in hospital at home. She's brighter in herself. Seizures remain variable, but so are her ketones. We've introduced a new medication recently, refinamide, to see whether that helps with the seizure burden, but then the next step is to try and push her ketones up to 4 to 6, but we're trying to do one thing at a time because of her unusual response to the diet. So therefore we decided to continue the ketogenic diet based alone on the reduced hospital visits from seizures. The difficulties for this child and us was the unknown and unpredictable response that we still continue to see. She's on quite a complex feed for mum to make up, which consists of Pepti Junior, collagen, liquogen, amino acid mix and diaurolite alongside potassium chloride. So we're asking a lot of this mum to do this, and there have been mistakes where certain products, the amino acid formula powder comes in a very similar tin to Maxijul, so we took that out and put Pepti Junior in. It's been a complex and interesting time, but things are stable at the minute, so let's hope that we continue and can get her ketones up between 4 and 6 without further hyperketosis.
Okay. Thank you.